6 presentation.
So good morning, everyone. I'll be presenting Riddle on behalf of Medicine 2. So presenting Mr. C, 49-year-old lady from Jharkhand, presented with the history of exertional dyspnea since 3 months and easy fatiguability since 3 months and intermittent chest pain since 3 months. History of presenting illness. She was apparently well 3 months ago when she developed easy fatigability and exertional dyspnea, which was insidious in onset. Her effort intolerance has reduced from 1 kilometers to 500 meters over the past 3 months. However, there is no associated orthopnea or PND as such. She also had this atypical chest pain, which is pricking type, intermittent, which is not related to exertion with no aggravating or relieving factors as such, which was disturbing her routine ADL. However, there's no history of loss of weight, loss of appetite. There's no history of evening rise of temperature, leg ulcers, or joint pains. There's no history. History of CTDs. Treatment history. She had developed fever in like 2 months ago with a headache and cough, which lasted for 2 days. For which she was evaluated elsewhere, found to have an anemia, which was with a hemoglobin of 4.5, requiring a transfusion. She was transfused with 3 PRCs. Her repeat hemoglobin after 3 PRCs was 8.5. 1 month later, she again her routine checkup showed hemoglobin has dropped from 8.5 to 7 gram. The past history wise, she has no significant comorbidities. There's no history of blood transfusion in the past. There's no history of similar illness in the family. Personal history wise, she had a second degree consanguineous marriage. Her obstetric score was P2L2 with no history of an abortion with all normal vaginal delivery. She's a postmenopausal lady. So vital side, she's stable. On general examination, she had a pallor with mild ictus, frontal bossing with malar prominence with malocclusion of teeth. Systemic examination was unremarkable, except her perabdominal examination showed a soft with mild tenderness in the left hypochondriac region, with a spleen palpable midway between the left costal margin and umbilicus, which is Hackett's grading of 3. Summary, Mrs. C, 49-year-old lady, presented with a 3-month history of exertional dyspnea, easy fatigability, and intermittent chest pain. The history of acute fall in hemoglobin during a febrile illness. On examination, she had a pallor with mild ictus, with frontal bossing, malar prominence, with dental occlusion, with systemic examination showing a left hypochondrial tenderness with a moderate splenomegaly. So we have a clinical syndrome of anemia, jaundice, splenomegaly. Our differentials were hemolytic anemias, hematological malignancies, leukemia, lymphomas, chronic infections like malaria and Kala Azar, with chronic liver disease causing portal hypertension, which is resulting in the splenomegaly and hypersplenism. Initial investigation showed a hemoglobin of 8.6 with a microcytic picture with MCV of 77.4, with a total count of 5,100, the platelet of 57,000. The LFT is showing a total bilirubin of 2.91, the direct bilirubin of 0.83 with mild elevation in SGOT, which is 43, SGPT is of 20, the ALK was of 89, with normal urea creatinine. Her urine routine was bland. Okay, so we evaluated her anemia. So we have multiple ways to classify anemia. One of the way to classify anemia is based upon this reticulocyte production index, which is less than 2.5, which tells us it's a hyperproliferative anemia. If it is more than 2.5, it's a hyperproliferative anemia. In our case, it is a hyperproliferative anemia. So in hyperproliferative anemia, it can be either due to hemolysis or hemorrhage. However, there was no history of blood loss as such. So we suspected a hemolytic anemia in her. The evidence for the same was she had an anemia with reticulocytosis, indirect hyperbilirubinemia, and elevated LDH. Few points regarding approach to hemolytic anemia. A hemolytic anemia can be classified based upon classified as inherited or acquired hemolytic anemia. In acquired hemolytic anemia can be due to immune mediator or non-immune mediator. So we ruled out immune-mediated hemolytic anemia. She has a normal indirect, her indirect Coombs test was negative. We suspected inherited hemolytic anemia in her.
Second. Immune-mediated, you said indirect Coombs test.
The direct, so
direct, yeah. Indirect is for what?
Indirect is for allo immune hemolysis in case of children's.
Actually, RH mediated. In
yeah.
pregnancy, you do. Okay. Direct.
So evaluation of hemolytic anemia includes if peripheral smear shows a spherocytosis with positive DAT test, it suggests you of immune hemolysis. If peripheral smear again shows a spherocytes with negative DAT test, which it signifies hereditary spherocytosis. If peripheral smear shows a schistocyte, it favors towards the diagnosis of microangiopathic hemolytic anemia. If peripheral smear shows a microcytic hypochromic anemia in the background of hemolysis, it is suggestive of thalassemia. If patient has a sickle cell in a peripheral smear, that again signifies of sickle cell anemia. If patient has a hemolysis with underlying after drug exposure like dapsone or primaquine, it favors towards the diagnosis of G6PD deficiency. If patient has a recent onset fever with hemolysis, it favors towards the diagnosis of babesia, malaria, all those infectious causes. So when to suspect a hemolytic anemia? If patient has an anemia with underlying intermittent jaundice, patient presented with a dark or cola colored urine with recurrent episodes of anemia after multiple transfusion, or else patient will be presenting to us with a crisis which includes bone pain with abdominal pain with underlying a splenomegaly. So the marker of which is increase in reticulocyte count, increase in LDH, increase in indirect bilirubin, and reduced haptoglobulin, which is the binding protein for hemoglobin metabolism. So in peripheral smear clues were if patient has a target cell in the peripheral smear, that again signifies thalassemia or other hemoglobinopathies. If patient has a bite cell or Heinz bodies, it favors towards the diagnosis of G6PD deficiency. So our evaluation, her immune workup was negative. Direct and indirect Coombs test was negative. DAT monospecific test was negative. Infective workup including HIV, HBS, AG, HCV were negative. Malaria was three malarial smears was negative. RK39 antigen were negative. Her bone marrow biopsy showed a cellular marrow with a marked erythroid hyperplasia with adequate megakaryocyte and scattered foamy histiocyte, which is pseudo-Gaucher cell. So about pseudo-Gaucher cells, is it significant to any particular disease? So no. So pseudo-Gaucher cell is a macrophage, foamy macrophage, which exactly resembles the cells that is present in the Gaucher's disease. It signifies as bone marrow has very high cell turnover, usually seen in the hemoglobinopathies, can also be seen in the myeloproliferative disorder and myelodysplastic syndromes. Coming back to our patient, our osmotic fragility was not done as the patient had a recent transfusion, which is in the past 3 months. Her hemoglobin electrophoresis showed a HbF of 20%.
Can I ask you a question?
Yes.
If your osmotic fragility cannot be done because of the recent transfusion, how can you do a hemoglobin electrophoresis in this patient? Hemoglobin electrophoresis is also contraindicated if you had recent transfusion, right?
Even though it shows a significant results like HbF was 20%, that should not be seen in the.
So what are you are trying to go towards the diagnosis of?
Sickle
cell
anemia.
Yeah. So what are the features on your clinical presentation which tell you that it's unlikely to be sickles?
Splenomegaly is there.
Yeah. So splenomegaly you will not expect with sickles. The problem if you do a HP electrophoresis after a transfusion is your values would be marked by the person whose blood you transfuse. So if the person whose blood was transfused had sickle cell, you might get a wrong positive sickle cell. Go.
So we expect a HbF level of less than 1% in normal adult population, and HbA2 of 2 to 3% in normal population, and then HbS should be absent in normal adult normal patients. So regarding this Menzer index, so when it is used, so this Menzer index is a simple screening tool used in the resource poor setting where they don't have an HB electrophoresis. So the formula for Menzer index was MCV by RBC, which is if it is more than 13, it again signifies as iron deficiency anemia. If Menzer index of less than 13, it is thalassemia trait. But when not to rely is when patient has an coexistent iron deficiency plus thalassemia, or any recent blood transfusion, or patient has an aplastic crisis, or patient has a thalassemia intermediate, thalassemia major. These are all the conditions when we should not like in our case, which Menzer index is more than 13 since she had a recent blood transfusion within 3 months. So coming back to thalassemia, heterozygous thalassemia sickle cell anemia trait. So it is a compound heterozygous hemoglobinopathy when one gene carries a HBS, which is a sickle cell gene, when one more other gene carries a beta thalassemia mutation. Usually this combination leads to the chronic hemolytic anemia of mixed type, whichever the predominant gene is. Let's come back to our case. If HBS is 61% in our case, so predominantly it's a sickle predominant disease. So it is of two type. One is sickle beta zero thalassemia, where there won't be any HbA. It's a severe form of disease. While sickle beta plus thalassemia, there will be a reduced HbA, but milder course, where patient will be presenting to us with a chronic hemolytic anemia. So global burden, it's approximately 5%
I
of the
think we
whole.
are running out of time. Just go forward.
Yeah. So clinical presentation, it can be either present as can be asymptomatic, chronic manifestation like chronic mild to moderate hemolytic anemia. It can present as an acute presentation, which is usually precipitated by infection, like as our case had a recent fever, which has precipitated the hemolysis. The precipitation usually are infections, dehydration, pregnancy, and surgery. They'll be usually presenting to us with a bone pain, or atypical chest pain, abdominal pain, and acute fallen hemoglobin. Can also present as a late presentation, usually in the fourth to fifth decade, with only they'll have a massive splenomegaly, pancytopenia plus or minus, usually confused with the hematological malignancy, since the population is an elderly population. These are all the few case reports that has shown the population which is more adult and more children and adolescent population, while the elderly population contributes to the very minor among the all the heterozygous sickle cell trait. What is unique about our case is a very late presentation. She remains almost undiagnosed for the 5 decades, which is usually highly uncommon. She had a massive splenomegaly. Usually, we expect sickle cell anemia to have an autosplenectomy, but persistent of splenomegaly at this age is a little unusual. And she also had a very high HbF, which can it can explain about her asymptomatic presentation. So coming back to our patient, she was started on hydroxyurea for sickle cell anemia. Genetic testing is done, results are awaited. Family genetic screening was advised.
Okay, sure.
Learning point, diagnostic approach, and then heterozygous sickle cell.
Any questions? What was the G6PD level for this patient?
It was the normal limit, sir, but I didn't put the exact. It was 10, if not.
So